associate professor of mathematics in San Diego State University in US. He has published many articles, research articles, as part of his academic career related to HIV co-infection, avian influenza, infectious disease control, like malaria, typhoid, etc. So he has been providing better knowledge to the science, to the world, in terms of bringing multiple disciplines together as a mathematician. Over to you, sir. Dr. Naveen Kumar Vaidya, are you?
Yes. Okay. Thank you very much. Thank you, chairs, moderators, and NHRC, especially for the invitation, and especially Dr. Demal and Dr. Gyali for the great opportunity. And this is, I'll be talking today about the mathematical modeling, actually, of COVID-19 in Nepal, key findings and its implications. So I'm mathematicians and I'm giving talk to this audience in 10 minutes. So it will be challenging for me, but I'll try my best. Okay, so anyway, so as I said, today I'll be talking about modeling COVID-19 in Nepal, key findings and its implications, so different perspective of talks. And this work is basically by our group. We have established the Mathematical Biology Research Group in Nepal with Kedar Upreti, myself, Ramesh Gautam, Anjana Pokhriel, and Khagendra Adhikari. And we are actually trying to promote the mathematical modeling to help for the management of the infectious diseases. And especially currently, actively, we are working on COVID-19, malaria, and measles. And these are the fundings we have received. So this is the COVID-19 in Nepal. It's just the data, just the case reports, the incidence data. And if we look at, I just want to note down, usually people call this is the first wave and this is second wave, but I would like to divide this first wave into two cases. July 21, where the lockdown actually started to relax. So that's a control phase before that. And after that, this is actually, I will call it first wave, but people usually call everything as a first wave. And second wave is around March 13, in the 13, 14, the second wave is started, and second lockdown is started from April 29. And September 16 is whole national-wide travel opening or something like that, okay? So I will try to give the brief outline. Like I said, it's a mathematical modeling, mathematical concept, so I cannot talk in detail, but I just want to tell you, we are really serious about developing model, and our model is data-driven. It's not like we did just for fun. So I want to give a 30-second snapshot of the methodology. I won't be talking too much, but what we learned from the past, that's I will be telling a little bit. And actually currently, we are actually timely giving the model prediction of what's happening today and what happens in the next 2 weeks, 2 months or something like that. So that's I will be talking about. And by the way, we have a website, I'll tell you at the end too. And in website, we are continuously, every day, we are actually giving updates on what is happening, current situation of Nepal through mathematical modeling. Okay, regarding the methodology, I will basically focus on two things. One is reproduction number. You might have heard a lot about R0, RT, reproduction number. It is extremely important index. It's actually basically it's just a reproduction. That means expected number of secondary infection produced by an infected individual during his or her infectious period. Like that means in average, one infected person, how many during its infectious period, how many new it can produce. So that number is actually reproduction number. And why it is so important? If we can track the effective reproduction number over time, this is actually just, it tells that RT greater than 1 or less than 1 tells us that currently whether our epidemic is going, actually it's in the increasing trend or decreasing trend. Just knowing greater or less, that it can tell. And most importantly, it is actually correlated with the policy implementation. So therefore, it helps a lot of policy guidance. Like a main policy has to be in such a way that that will make the reproduction number as less as possible. Okay. So then we have in this paper, all data that we are using maximum likelihood based method. I'm not going to tell anything about that one. It's all about in this paper. And now next thing I'll be talking about is dynamical model. So basically that's about the differential equation based model. So and the details is in this paper. But again, to give you a 30-second snapshot, what we do is this in the model. So there is a reality, the infection is going on. Then our goal is to develop some kind of description of the process. Same as like you can think of the regression analysis. In there, your description is the things change like a line with a constant slope, right? Same idea. We want to develop that. And then with some experiment, measurement, and survey from the reality, we get a data. And in the model also, there are certain parameters describing all these realities. And through these parameters, we can get a solution. And that solution also gives us model prediction, what we have in the data. Then we work really hard to fit and match models, same as the regression line fitting, but it is very complicated. And then we get the best parameter. And if our model prediction and data are equally, they match each other, then we have at least our model is valid, and we can at least use our model to understand different things. Okay, so this is our model. So if you look at from the April to almost today, actually July 1, this is the data, incidence case reported data, and the rate curve is our line. So there are so many ups and downs in this curve, and it's very rare to see that our model, like our model, it's very rare to see in the literature that the model is doing excellent job. It almost covers whole year's epidemic. And if you look at cumulative number, it's excellent fitting. So that tells us at least that our model is valid. We are very happy with this result. Now, what we learned from the past, I'm going to tell 3 things that we learned from the past. Number 1, we calculated reproduction number. If we compare the same data, control phase, like a first wave, at the beginning of the first wave, if you look at that reproduction number, it is below 1, below red line, consistently until July, until the lockdown opens. Then even after lockdown opens, there is an increasing trend, but it is not too high. But this second wave, if you look at the second wave, right away, way before actually lockdown starts, this actually, it's already greater than 1, and magnitude is also very high. And that means there are clearly 2 differences in the waves. First wave is actually very well controlled, first wave. And what the second wave, before the lockdown, there is already community spread in the second wave. So that is one thing is different. That's why we are having hard time to control disease. So maybe lockdown has started a little bit slow. And why is that? First wave was so successful because it's a border screen and quarantine, lockdown, and detection and isolation. These are the 3 policies government implemented at that time. And we did that. This is reality until July 21. If that policies were not implemented, it would have been almost 15,000 per day case already in the July. But that time it was really successful. Government's policies were really good at that time. So then we also did among these 3 control strategy, which one is more effective? And obviously lockdown seemed to be the extremely effective, but others are also effective. But interestingly, because we have a border screen, lockdown, detection, isolation, but our geography and related to borders and everything, and contact patterns, urbanization, so much different varieties among our provinces, then what we did is, we did detailed analysis on each province, and we try to see that which actually among these lockdown, testing, isolation, and quarantine, which one is most effective in each province. And what we found, this red one tells us that effective. And what we found interesting, it widely varies among provinces. So then there is a provincial disparity. Then what we learned from here that even though government implemented national levels, but there is a way different. So that's why we cannot have a same model for everywhere. So that's why we started doing high and low risk regions. Now, when we did that, now current and future, I'm going to tell you every 15 seconds one information, today's situation. Let's see. This one is today. Effective reproduction number today is July 1. We have in the whole Nepal, it is 0.9. In in actually high risk region, it is 1.06. Unfortunately, it was already below in high risk region, but it's already up in couple of days. So it's growing up again. And in low risk region, it is 0.85. And we can use our model to do the model prediction of the seroprevalence. And roughly until July last year, where there were control, only 0.1% seroprevalence. Now on the March, after the first wave, we predicted around 23% seroprevalence. And now today, as of today, we roughly predict around 47% seroprevalence in Nepal. So then what we did is, this is actually the daily reported cases. This is again data and until today, this line. And we also did, okay, if this lockdown continues, what happens? So this is the rate curve. And if we relax, we go back to the pre-lockdown stage, what happens? It might go this way. And
Dr. Naveen, you have
75%
2
opening.
minutes to wrap up.
Yes, sure. So I'll be done by 2 minutes. Yeah. So you have this, if you have a 75% open, then we get this peak sometimes in August, and it goes down. If you have a 50% open, we have blue card. So then same thing in the high risk region, and in the low risk region, we have similar cases here. So then idea is, now we also, what happens, we also try to find the medical care. What is expected medical cares for the next 2-3 months until December. So this one will see total available. Maybe if we completely group pre-lockdown state, we may little bit overwhelmed with the medical care need, but otherwise we will be okay below the capacity. ICU bed, we are still okay. This is the available patient for ICU bed in Nepal, but we will be below that still. And also patient ventilators, that also below this line means we won't be more than the capacity we have. So then what we now, this is the last slide actually. One of the key questions we are always interested is, we are tired of lockdown, but can we relax the lockdown? So then only way of relaxing lockdown we see here is vaccination strategy. Then what we did here is, this is the level of relaxation. And this is the, if we 80% people we vaccinate by certain time. So if we vaccinate 80% people by January only, so if we do that 80% at least by January only, so then we might still get, if we don't do any lockdown, we might still get one peak around 8,000. But if we 60-70%, we might be in the current situation. If 70%, we can relax the lockdown. But if we aim to vaccinate, really optimistic, and aim to vaccinate by August 1, let's say 80% people, then we can actually have a 45 or just around 40-50% lockdown. Also, will do the relatively good jobs. Okay, so this is one example only, but we can produce a lot of results like this. And now, in my conclusion, dynamical system model can accurately explain the COVID-19 case. We can see very well for the case of Nepal. Model are extremely valuable for timely prediction and evaluation of control policy, and also combine non-pharmaceutical policies that actually implemented in Nepal before July 22 was highly successful. We really have to appreciate what government did at that time, save a lot of lives, a lot of cases. And actually looks like combination of non-pharmaceutical policies somehow balanced, not exactly going lockdown, open everything, but in the relaxed form, little bit in the balance along with the vaccination might be right strategy to move forward to control the, for the control of transmission, medical care, ICU patient, as well as ventilation. And looks like in a long run, only ways, of course, that I have experience here in US. Now it's the condition is better in US. Way for the long-term control is still is the nice vaccination policy. Okay, so this is the group. Thank you very much. If you have any questions, comments, I would love to take that.
Thank you very much, Dr. Naveen, for your excellent presentation. This actually highlights the true integration of the interdisciplinary research in terms of